I'm Dr. Darren Sharpe. I'm a senior research fellow based at the Institute for Connected Communities at the University of East London.
I'm Dr. Winston Morgan. I'm reader in toxicology and clinical biochemistry, again in the School of Health, Sport and Bioscience. I'm also Director of Impact and Innovation. In addition to my scientific work, I've sort of developed an interest in outcomes in higher education in terms of for students, but also for staff, and also medical outcomes in wider society based on race and ethnicity.
So my name's Gail. My job title is Director of the Office for Postgraduates, Research and Engagement. I'm not a researcher, but my role historically has really been about public engagement and community engagement, helping to connect communities to our researchers for mutual benefit, really.
My name's Simone Gordon. I'm a level 6 public health student at the University of East London, Stratford.
What started to emerge quite quickly from that was specific challenges that our local borough was facing that may be different to the sort of the national challenges, or maybe enhanced, harder challenges. So we were hearing lots of things externally, and then colleagues internally were talking about the knowledge and the skills that they had, which were able to respond to some of those challenges. So I think the first sort of piece of response really was just sort of hearing those two sides, and then colleagues starting to come together, internal and external, to start to respond to those.
Although I stated I'm part of the Institute for Connected Communities, previously, up until last summer, it was called the Institute for Health and Human Development. And over the last decade, all the team had always been focused on doing participatory kind of community-based research in Newham and broader, the east of London and nationally as well. But we'd accumulated a lot of data in terms of health outcomes, and we'd also worked with the public sector quite intensively. So I knew and I was aware that we was in the right position, A, in order to access and utilise all the data we'd collected, and B, having the expertise, be it sociologists, which is my background, epidemiologists, and other kind of professionals what deal with the array of kind of health and social issues, what COVID is presenting in the very early days. Then when we learned about the disproportionality in BAME communities, that was the second trigger really. And when it came to the Public Health England report, what we're saying, basically, we needed more evidence. However, the community was saying, well, you've been collecting evidence for the last decade, 2 decades, 3 decades. We know what we already know. So what would this exercise actually tell us, what we don't already know? And that kind of validated all the data we're sat on as well, where we knew why the BAME community would be disproportionately affected when it comes to the quality of their healthcare, accessing healthcare, as well as just like life, the social determinants of health as well. So we knew the starting point from where the community were starting from in terms of we want action, we don't want more research into our pre-existing problems.
As I said, I'm a bioscientist, so there's a lot of work that we do in the laboratories, for example. And around the time we were having lockdown, it was a time that I was going to hope to spend more time in the laboratories, either with my undergraduate students or my PhD students, or with my researcher colleagues in the laboratory. And suddenly we couldn't do that. So that was quite a surprise. Then I started looking at what's happening around the early part of the pandemic. And for me, as I said, I'm a reader in toxicology, amongst other things. I went to my local supermarket and I was trying to find cleaning agents and bleaches and that kind of thing. And I went to about 5 or 6 supermarkets and there were nothing. And what started clicking in my brain was the impact this would have on the environment and also on antimicrobial resistance, because if people don't use these cleaning agents properly, what you do is you effectively encourage more resistant bacteria to breed. And so that's what was my focus. Then I started watching the news a bit more, and particularly the government messaging around what was happening. And then the data came out. Darren spoke about this disproportionality for communities described as Black, Asian and minority ethnic. And all the time there were no clear explanations, and I was kept waiting for someone to come on and say, these are primarily due to sort of deprivation and social factors and that kind of thing. And yes, they partly mentioned those, but there was always this hint that some of these factors were due to genes linked to these particular groups. Now, as a scientist, I knew enough to know that this is highly unlikely. There's no genetics, there's no biological categorizations, these are social categorizations. So for senior scientists and politicians to be hinting, without actually saying that these were linked to people's genetic makeup in some way was wrong. So that's when I started getting involved and started writing articles about the topic. And then things sort of exploded, if you like, from there, where I felt one after the other, I had to sort of write different articles to address different issues. It was clear very early on in the pandemic that because the university is going to be part of this lockdown, we weren't going to have a lot of international students, for example. And I knew that if student numbers go down, it's going to have an impact on university income, and obviously on the number of staff we could employ. We might even lose staff. So one of the other things I wrote about was, if this is going to happen, how would that impact on BAME colleagues? Because again, looking at the data that I'd seen in the past, whenever there's this kind of stress, both in sort of medical area or in this kind of employment area, it's usually BAME staff or patients or whatever who are going to be most impacted. So I was watching and seeing how the university would respond to that. So those are sort of the two areas which got me going early to mid-pandemic.
For me, as I'm sure you all know, as a student during lockdown had its challenges, but it's also had its positives. Through a few internships, I was fortunate enough to work on the Well London project with Darren and his team, where I managed to pick out a lot of things. And I agree also, for me as a student, I feel the same way doing my own research and my own critical analysis. And I feel like, again, with the pandemic and trying to access, cleaning materials, how that impacts people, the misinformation that's going around in my community, the amount of things that's being said in our community right now in the Black diaspora, that nobody has faith in the health service, nobody has faith in the vaccine, nobody has faith in the law enforcement or the judicial system. So how is that impacting us as a community from a wider perspective? I don't know how you guys feel being in the field so long, but I'd like to know, what do we do now? Where do we go from here? What do we do?
And what I think we forget during this health emergency is the Black Lives Movement. What happened smack in the centre of it, how that reverberated globally. And if anything, if we didn't listen to the disproportionality in BAME communities at the beginning of COVID, who was losing their lives or being hospitalised for COVID, as Simone said, it shone a spotlight not just on health inequalities, but policing, social justice of Black people and Black lives. And in response to what do we do next, I know this government is committed to levelling up and trying to kind of reduce the north and south divide. Really, I think if any lessons can be learned from this pandemic, it's the inequalities not all Black and not all ethnic minorities are living in. Like myself and Winston, we've had a very privileged position during this pandemic. We've got job security, we earn good incomes, we've got good health, and that I'm sure mirrors with our families. So I'm not homogenising and saying every BAME individual is in the same boat. But nonetheless, a disproportionality of BAME individuals do experience extreme social inequality. And so, yes, the focus quite rightly is on levelling up that south and north divide, but there should be a more intense levelling up when it comes to BAME individuals in British society, and not just providing opportunity, but I don't know, it's getting to the roots of the problem, but not just tackling the roots, it's looking at it throughout the pipeline, what needs to be tackled from a governmental level.
The disproportionate impact was known quite early after the first wave of the pandemic, and we've been hearing about calls for action and doing things differently and tackling, how can researchers and how can our sort of wider UEL community be part of that? What is that action? What do we do now? What are the next steps?
I will answer that bit, but just going back, I get one of the things I forgot to say. When I saw the data, and it is about data, on the disproportionality, one of the things I was able to do is just sort of map it onto educational outcomes or, for example, things that happen with Black people in the police or health. All of these things, you can map them on COVID data. So I knew that this wasn't new or surprising. And also, we've been talking about inequalities in education for many, many years. And whenever that we come to a kind of crossroads, people say, let's do some more research. And then people like me would say, no, we've got all the research. We know what we need to do. We've just got to get on with it and put in place these actions. But a lot of these actions, they're quite challenging because inequality creates disadvantage, but it also creates advantage. So when you want to put in place a solution, you are going to have to take some of the privilege away from people who have it. The only way you can level up is if you put more resources in. So because otherwise, again, you're going to have to take things from people who have it and they're not going to want it. So this argument of saying we really want to level up without creating a larger pot, if you like, it's not going to happen. And I think that's one of the big mistakes. In terms of research, I suppose there is research, but it's also you need people who understand the research to take it on. So what you might find is people like Darren is doing good research, but then the decision makers, the people in key positions who are taking that research on and making it work, don't have the understanding to actually do that. So not only do you have to have researchers in the right position, but you also have to have sort of like managers and decision makers and gatekeepers who are able to understand that research. So basically there's a huge structural problem with our society. For example, you don't just tell people to take the vaccine. There are structures that have been dismantled or haven't been built up, which enable certain communities to get a vaccine. And until you put those in place, you could say until cows come home, as they say, you will never get that to happen until you put it. You sort the structures out, and that includes things like trust in both the government and the NHS, which doesn't exist in a lot of these communities for lived experience reasons. I haven't even mentioned the other point that Darren made about George Floyd. That was so key because you had the COVID and the inequalities, and then you actually saw again that with your own eyes, and that not only sort of created awareness in the AME communities, but in white communities, that this is really happening, because perhaps that's the first time people had really engaged when people had said, how they're treated by the police, for example, and people would have ignored it. But when you actually saw that, that was so key. And also the writings, some of which I think I contributed to, about medical racism. Again, people may have heard about those things in the corners, or it was in their memory somewhere, but it's when you actually read it and see examples, and then people think, right, okay, there's a lot going on here that needs to be addressed.
You talked about conversations coming out of the margins into occupying more space, occupying perhaps different spaces, more people having conversations, hearing conversations. And I just wondered, you've both been in, I think, sort of public events where we've got mixtures of doctors, academics, public health leaders, communities, faith leaders. How valuable is that? And what do you feel about the conversations that are happening in sort of an occupying more space?
Yeah, myself and Winston, and Winston's, gosh, he's hosted a lot of these conversations, and I've been party to a lot of them, a fly on the wall. And the ones I've actively participated in or listened to, I think they've been really rich and worthwhile and instrumental discussions. So you often add groups of either social care workers or residents who have kind of self-nominated themselves as community champions, is one example, or a classic social worker. And they've interfaced and they've been able to ask their questions to professionals such as Winston, and they've been able to take away nuggets of information for their own and their families' welfare, as well as being an instrument disseminate across the community. And so so it's been really productive, and the outreach has been fantastic, and we at UEL, we've been part of that outreach. However, my only concern is that I still feel that people really on the margins, their voices haven't been accepted. And I doubt it very much that the social workers, they will only communicate with people on their books. Equally, the community champions will only communicate with people in their network. And it's the most vulnerable, and it's the classic scenario, really. It's the most kind of marginalised, the most silent, which I feel hasn't really engaged in this process, and we haven't really developed the mechanisms really to reach them. And ultimately, it's those at risk, and whether it's BAME or whether we're talking about Indigenous white members of the population, it's those vulnerable individuals. And it's those individuals I've seen really throughout my career as a sociologist, whether I'm doing work in the judicial system or vulnerable or troubled families, or whether it's children who are experiencing really bad educational problems. It's those individuals what I believe are excluded from this discussion and lack the protection to protect themselves and their families during this pandemic.
That's so powerful, Darren. Spot on. I couldn't have said it like that, but that's exactly what I've been thinking. Like, what about those people that lack that literacy, that lack that understanding, that don't have that knowledge? How are they being impacted, and how are they coping? How is that impacting their families from a wider perspective? I've been thinking that myself.
I was also thinking that, I mean, as Darren said, I take part in a lot of these, and I'm always aware that, because, as Darren said at the start, that I benefit from a lot of privileges, education, and I'm always worried that, is this really just an academic kind of exercise, or is it really penetrating? Am I really authentic? Because a lot of people will say, and I've had this said to me on more than one occasion, that am I not just basically the representative of the system, trying to infiltrate and get them to do what they don't want to do? So it's really a challenge around authenticity and trying to represent people in a certain way without sort of I don't know, and also having them believe in what I'm saying, and that I am actually genuinely on their side, and not be on the side of, if you like, the system that's disadvantaged them in the first place. And it's a really, really tricky one. So I'm aware of it, and I challenge myself all the time not to become part of just someone who repeats what the government says or what the NHS says because it suits me in my career. I'm always trying to ask questions about what they're doing.
Oftentimes you find that Black women find themselves conforming to things and just doing things and forgetting their whole sort of motivation behind and purpose behind, what they're trying to do in their role and what they're trying to achieve ultimately. And it's easily done. I've seen it. I've seen my family members do it. They've had good positions, and they end up just doing what the NHS says, or just doing what the judicial system says, and there's no change. And it's important that we remember this on this journey, this continuum of work. It's important that we don't forget and drop the baton, because I think that's what's happening. And again, we do need those resources, but I think we have those resources amongst ourselves as well. And we do need to level up so that we can take that further step. It's really important that we don't forget what we're actually trying to achieve on this journey, on this continuum of work.
How I positioned myself, actually, in terms of the work I've been doing. At the beginning, I was really kind of eager to get engaged in the field at the beginning of the pandemic. And quite rightly, I had to pause, and I went back to the World Health Organization kind of guidelines and the work they've done globally in tackling pandemics. And clearly, in the first stage, it's a medicalized problem. And I'm not a medical doctor. And so that was like the first emergency response with the healthcare workers, which is understandable. However, there is a role for social science later on in terms of kind of getting to the roots of the problem and understanding the broader impact of the pandemic on populations. And so I entered the field near to the back end of the first lockdown period. And there was numerous ways, a couple of different ways actually, I kind of engaged. Firstly, I always historically had connections due to a global research challenge fund, what had been issued through UEL to work with Zambia and Sierra Leone. So there was pre-existing relationships there. The project was just about to get started, and it was premised around empowering vulnerable and disabled young people, getting them into the economy. However, we had to pivot. And what we actually did instead, we took the lessons of shielding from the UK and we transferred it over to Zambia and Sierra Leone. And we provided PPE, we provided food aid, and we provided health information in relation to COVID. And so we focused very much on the vulnerable, disabled children and their families, and tried to kind of literally shield them during the first kind of COVID period, the first wave. And so that was a kind of an international piece of work, very worthwhile, and we succeeded in kind of supporting thousands really of young people through information, as well as food, as well as masks. Then during the second wave in lockdown, my attention shifted back to the UK, and working with Gail and Winston, actually, we connected to a number of public health entities within Newham and East London. And so we worked with the NHS East London Trust primarily, and they have a number of disproportionality or task and finish groups, actually. And I'll ask Gail to talk more about those in a short while. And also Newham Public Health Team. And so collectively, we work on a number of different projects. And we kind of, I guess, functioned as a research arm to these teams. And we kind of increased their capacity in order to kind of get insight and then respond to the needs of the community as it related to COVID. And so one particular area we looked at was test, trace and isolate. And there was two parts to this work. The first was about refining their test, trace and isolate system. What they found was that people were not volunteering their contact details, so the people they'd been in contact with. And of course, that kind of interrupted the system in terms of reaching out and getting the message to isolate to members of the population who'd been in contact with somebody who were identified as having COVID. Later on with the test, trace and isolate, it was more about understanding why individuals weren't isolating when they'd been advised to isolate. They knew the numbers roughly, but it was about drilling down into their data sets and their surveys, what they'd administered, then actually finding out who are these sections or subgroups in the population, what their issues actually were, what was preventing them from isolating, but more importantly, what the council could do to intervene. So what was in their control to support them to isolate, what they could do as an institution to lobby across the council to find solutions, and then also thirdly, what was out of their control. So looking at more of the structural issues, which I guess would be more long term. So that was one piece of work. We also did two other pieces. We did two rapid literature reviews, really. One, what Winston led on, looking at vitamin D and in terms of boosting the immune system in BAME individuals as a kind of the first protective barrier against COVID, staying well and healthy. We also did a rapid literature review looking at vaccination take-up amongst BAME communities globally. So we wanted to learn the lessons. This was well before we actually had an approved vaccine. So that was a bit of prep work before we had a vaccine and before rollout would begin. And we also, like I pertained to earlier, we ran a number of community conversations to delve deeper into certain pockets of the community, like the social care workforce, just to understand what their needs were and what their emerging needs were around contacting their clients, as well as kind of sharing vaccination information. And so all our work really is kind of fed into task and finish groups where they wanted kind of rapid research in order to help shape their decisions. So this is classic evidence-based decision making really, which they can then turn into action. And so I've been pretty proud actually to be part of that process where, due to rapid research, rapid insights, we've been able to turn around things in a rapid way and actually serve the community. One classic example of this work is just really better promoting the fund, what Newham Council could actually give individuals to isolate, with finances being a barrier to isolating.
What I think has been really powerful and potentially something to build on is colleagues in the room, Winston and Darren, and other colleagues who have been able to respond rapidly and have been able to kind of do the literature review, do the very quick, often turnaround analysis of data that has really helped colleagues in Newham Public Health to then inform their decision making. So how we were talking earlier about the, research has been done and we don't need research, we need action. But actually what I've seen from colleagues is that ability to, yes, there's research there, so let's use that. Let's quickly sort of pull together the key findings, the key outcomes. And I think what that started to create is a really strong platform for future working and how researchers, public health, wider health, communities, how we can work together to really sort of continue on that evidence-based, evidence-informed decision-making. And I think for me, one of the things that's really important is kind of now, really, we're sort of coming to the end of this first phase of, it's beyond the first wave, but it's the first phase, and where everybody is now talking about the recovery plan and the recovery position. But what does that mean in terms of equalities, and what does that mean in terms of how can we work differently, collectively, in partnership, to really put things in place that are going to make the difference long term? Because as colleagues said earlier, the research is there. We know the historic inequalities, we know the current inequalities. Well, what do we do now? But we've got some bits of framework, I think, and ways of working that I think will be really useful going forward.
Just to sort of follow on from what Gail just said about going forward, and one of the messages that's been sent to the public is that we need to get back to normal, and getting back to normal for a lot of these disadvantaged communities isn't really a great incentive. So what I'm hoping that government and other people in the local authority will be offering is more than normal, that things are going to change, that things are going to improve. Now, and another point I want to make is about, I've been working at UEA for over 25 years, and this is the first time that I have seen UEA, which is supposed to be East London University embedded in the community, actually do that. At least from my area and my department, we sort of like dabbled, but I know Darren's team particularly, they've always done that, but the rest of us, we've really not done that. And so what I really enjoy is the sort of interaction with Newham Public Health, for example, and I'm also Director of Impact and Innovation. And that's what part of the role is to actually take the research that we do and the academic and the intellectual knowledge into the community and actually change things for the better. So this is, I think, a positive change for the university, that we have to go forward with that rather than retreat back into our ivory towers, or however you want to describe it, and sort of ignore the community. We should now be within the community, doing more participatory research, all those kind of things. We're at a crossroads, as it were, in terms of how we work as a university in East London. And it's also one of the things, it's a very rewarding thing to do, because suddenly you're talking to people who are actually being impacted on either the research you've done or the ideas that you've come up with, and that's really rewarding, and we need to do more of that.
And if I can just briefly say as well, although we've had a tradition of doing that as part of my team, I've never experienced it at such a kind of quality, and that partners have been so receptive. And you can appreciate the richness in the discussions we have, and then you would have witnessed research is only one element of that discussion. And what we produce from those kind of meetings, I don't want to lose. And so the trick is, how do we embed ourselves and build on these relationships going forward?
Absolutely. And again, on that, I think that's right about what that might look like, because I don't think we knew. So when we, as collectively, as a group from the university, said we want to support, we don't quite know how to do that, but we have all of this knowledge and skills here. We didn't quite know how we were going to do it, but everybody kind of was brilliant at saying, well, let's explore, let's see what we can do, let's get together, let's go to the meetings, let's listen. And from that, a range of pieces of work, collaborations has emerged. I also think our students have been involved in some of this work, and I think our students are such a brilliant resource and font of knowledge as well. What more can we do? I think there's real appetite from our public health colleagues actually to connect more to our students.
Yes, we saw that also in terms of our student. That really made us proud when we set up the test centre to test student and staff. We always knew what our students were capable of, but it's actually being able to put it into practice really quickly. It's something that it was confirmed, if anyone had any doubts, that our students could do these kind of things. So that was another rewarding thing to observe.
Yeah, I have had the pleasure of working alongside over 70 students have worked in the test centre since November, and I've had the pleasure of working alongside them. And their ability to learn quickly, adapt, offer a fantastic professional service to staff, to students. There's new training, there's new things we have to do. We have to keep up with all the standard operating procedures. And we've had students who've actually trained now other members of the community in the lateral flow testing and system. So we've seen it sort of come full circle in just like 3 months worth of activity. But it's been a real pleasure to work alongside our students, definitely.
In the middle of the pandemic, I always go back to this because I think it's quite important, talking about the government, they were put under a lot of pressure to do a review of why BAME, particularly black communities, were so disproportionately affected. And they commissioned the Public Health in England and Professor Kevin Fenton to do a report called, I think it's called Beyond the Data. And at the end of that, he really sort of captured what needed to be done. And that's really about, he made 7 recommendations, and all of them effectively said, we need more BAME, particularly black scientists, doctors, public health officials embedded into the NHS and also in the right level so they can make the right kind of decision. So going forward, that's the kind of thing that I want to see action taken on. And when I say training, not just because, for example, we produce a lot of public health graduates and public health master students, but how many of those get employed in places where they can make key decisions within their communities? And that's what we want to see. I mean, some of our bioscience students go on to do medicine, for example, but again, I think we need to have more of those because I think that's where the deficiencies lie, both in terms of how COVID impacted on the community, but also now in terms of how people are being responding to the vaccine uptake. Again, they're not hearing enough from people who they know and trust saying the vaccine is safe and effective and they should be taking it. And so that's opening up the space for others to go into and cause that in their head. So I think training more BAME, as I said, particularly black staff in all these key areas, if we're talking about healthcare and social care and all those kinds of things, I think it's going to be really, really important going forward. So that when the next pandemic comes along, you've got people both in positions to make key decisions at the right time and knowing the data and knowing the people and knowing the outcomes so that they're not disproportionately affected, but also being able to stand on TV next to the Prime Minister and give a different view or give a view that all represents everyone in the community, which isn't happening now because there aren't enough people in those positions. So going forward, that's what I want to see.
One was around BAME disproportionate disproportionality, and these are social constructs, which I totally agree with. And I think the simplest way I've always articulated it, poverty kills, regardless of your colour. And it's because a lot of the BAME are in either low income jobs or in no jobs, why we've seen that disproportionality due to the circumstances they live, which of course warrants a structural response. And I'm hoping that COVID is being that disruptive factor in society, to be quite honest. And as we've seen with the Black Lives Movement, like Winston also articulated, it wasn't just a new awakening of Black consciousness, it was a new awakening of white consciousness. Everybody's eyes could see it clearly, unfiltered. We all saw the same phenomenon in front of us. I want that disruptive factor to continue. And in terms of kind of a structural response and actions behind that, it's all incremental. It's a collective action on multiple levels in lots of different corners of society. And one crystal or clear example is, again, we can go back to evidence, what looks at educational underachievement by Black Caribbean boys, for instance. Then if you look across schools and across the national curriculum, what initiatives are actually in place to actually focus in on Black Caribbean boys in order to raise their educational attainment and get them into higher education? There is none, barring Sunday schools, what are run predominantly by Black churches. I know that's where I got my education and where I got a sense of self through my Sunday school, for example. I didn't get my esteem from my formal education. It was my informal education where I got my self-esteem. And so there is no structural, so that's one simple structural response. And it is about raising aspiration. So it's bi-directional. It's a commitment from government and those in authority, those with power, to value all the assets in society, including BAME individuals. But it's also for BAME individuals to recognise themselves as assets and have aspirations and hopefully meet each other halfway. But it's everybody needs to be involved. This is collective action, and there isn't one solution that will fix this problem going forward.
I agree with the comments made about holistic approaches needed in terms of, I think there's also space in education to do things differently now. And there was some interesting discussions last night, Newham Community Leaders Forum, about not seeing it as deficit, catch up. These children have missed all of this, but actually thinking about educating students, young people differently, looking at strengths-based approaches, looking at, what we're educating for, who are we educating. But I think just in terms of, there is the space to also look holistically. Those spaces are sort of open for conversation in the same way. And I think the only other thing I would add to what colleagues have said so far is, I think this has opened up listening spaces. I think we have been listening to communities in different ways collectively. Public health have done this, other health have done this, we've done this. I think if we can keep that listening going forward, because the solutions are there in our communities, if we can find the ways of supporting community-led initiatives and community actions, that the knowledge is there. If we can partner up in the right ways, I think we could potentially be doing things holistically and very differently, and valuing the voices that we have. I appreciate what colleagues have said. We still haven't heard everybody we need to hear, and we're still not reaching everybody we need to reach. But I think there's been some steps in the right direction and some things to build on.
One of the brilliant things, or one of the sad things about the COVID data, is that when you take away all of those things, all of those factors, there is still disproportionality. And so we then have to challenge ourselves about, it's not just being poorer or being living in certain areas. There's also something else that we don't like to talk about, and it's just straight racial discrimination that impacts as well. And that's what the COVID data, when you look at the COVID data, when they control for everything else, there are still these disproportionalities. And we know, as I said, that's how I got involved. It's not genetics. And then the only thing I always see there is that there's simple discrimination, bias, whatever it is, in a sense, because this is structural. Again, people don't even realize they're doing it, because the system enables. That's what structural racism effectively does. It makes discriminatory actions easier for people who are doing it, not realizing or not having to confront themselves and look in the mirror that they're doing it as they're doing it, because it's part of the structure, it's part of the policies and practices of this organization. So what COVID has done is not only reveal the impact of deprivation, as I said, and all those kind of other things, but it's also gone further than that, because we've had to look at the data. It's also told us that in our society, sadly, decisions are being made simply based on race and bias, and that needs to be spoken about and changed, and that's what I think hopefully we're going to take forward.